had that set up in the womb. It had already had pulmonary hypertension set up, and a lot of us had already aspirated before they were born. And yet we just don't see that much anymore. Pneumonia. Pneumonia is just one of those sort of garbage can things. If your lungs don't get better on chest x-ray in your term or near term, and it's a couple days out and you still have an abnormal chest x-ray, you get called it pneumonia. Because you don't know what else to call it. It may or may not be an infectious pneumonia. Congenital malformations, pulmonary hemorrhage, which is only something you see at very small, very creature infants with sick lungs. Upper airway obstruction and problems with transition, which is tied with TTN, and those two get lumped together a lot. That's probably the largest group, as if we're talking about term and near-term kids, that slow transition, TTN sort of stuff. Those are going to be the majority of the kids that are growing after delivery. The non-pulmonary things are not very common. Congestive heart failure, which you're talking about a baby that has either got a heart defect or has had a severe perinatal asphyxial insult that has damaged the heart. Persistent fetal circulation, baby that's got real high hematocrit, polycythemia, hypoglycemia that's bad enough to cause persistent respiratory distress is something that is almost unheard of. Certainly kids that have had some sort of central nervous system injury, whether it be a hemorrhage or meningitis or whatever, they bleed fast for central reasons. Neuromuscular disorders, anemia, and other infections, so the pulmonary is far more common. So this approach that Iowa came up with was developed over a 25-year period. They've been doing this a long time in Iowa, having their perinatal care group. And what they have just used as a general guideline, again, this is more agreed to common sense than it is scientifically based. And so they decided that within a 2-hour period of a baby developing respiratory distress, you need to make a decision on just transfer or not to transfer. And the feeling was that 2 hours was sufficient time to determine if the baby has mild self-resolving respiratory distress or if this is something that's more worrisome. And if it looks like the baby has got persistent respiratory distress, they're supposed to get a chest x-ray. And then they have these criteria then. So, if the baby has respiratory distress that is persistent for 2 hours and has an abnormal chest x-ray, that baby needs to go somewhere. If the baby requires more than 40% oxygen to be adequately saturated, and again, they use 95%. If you're looking at something like a stable program, they pick 90%. So it's what your community agrees on. Certainly if the baby is getting worse, that means the baby needs to be transferred. Now, after 2 hours of watching and the baby is no better, then they need to go. And if uncertain, then call the neonatologist at your referring center and kick it around with them about whether the baby needs to go or not, and make a decision to watch for a little longer, or, we better come get that baby. Now, one thing that, there's been this, I think, a drive to, in many centers, to try CPAP and high-flow nasal cannulas. And a lot of that is to, for those kids that are going to have a transient respiratory distress, to have them stay in the hospital and get through that hour or two till they're getting better, which is fine. But if you're moving, and one of the points I make there, if you're using CPAP, that's positive pressure, and you're moving into being a neonatal intensive care unit, if you're going to use CPAP for an extended period of time. You can make that argument for high-flow nasal cannula. And I'm not talking about just initial stabilization while you're seeing if the baby's getting better. But if you're gonna say keep a baby on CPAP for 36 hours, or even a high flow nasal cannula for an extended period of time, there are additional things that your hospital really is going to have to bring on board to provide for support. And that's because the fact that you've got a baby with persistent respiratory distress on some sort of positive pressure support, you are now taking care of sicker babies. This is not a transient respiratory distress. Now you've moved into something else. And the need for things like blood gases, sudden chest x-rays, and the incidence of this baby critically becoming sicker and needing a chest tube put in or intubated is higher in that group of patients. Just use an example of, I took care of a team in our NICU for a 4-day holiday, and they were, the entire team was out of sorts the whole 4 days, and there was a set of 34-week twins that were born on Saturday. And I asked them, please put them on my service tomorrow because I want 2 kids that are just going to behave. So both these kids were on CPAP, and the bigger of the 2 the next morning blew a tension pneumothorax, had to have lines placed in, then had to intubate them, put them on the ventilator, had pulmonary hypertension, and everybody's going, yeah, well, next time you ask for normal kids. Well, I didn't ask for this. But you never know, and if you're going to elevate to taking care of kids regularly on CPAP, that's what you're going to get occasionally. And those kids are going to sometimes go from being okay on CPAP to this baby went to 30 on a high amount of O2 when he popped a tension pneumothorax. And so, we had a chest tube in him in 15 minutes, but you were taking care of a sicker group of patients. Now, if you're going to provide supplemental oxygen, as we all do, then you can do it by a number of different ways. The ways to start with are either an oxy hood or a low flow nasal cannula. Low flow is probably 1 liter or less, but many places would define it as half a liter or less in a newborn. I like oxy hoods, and the reason I like oxy hoods is that if you have somebody on a nasal cannula at the lung level, you really don't know how much oxygen they're getting. That in an oxy hood, if they're in 50%, their lungs are probably seeing pretty close to 50%. If you're in a nasal cannula on 100% at 1 liter per minute, they're probably seeing something like 30%, or it depends on how much they're breathing through their mouth. There's a lot of mixing in the nasal pharynx. So if you need to know how much oxygen somebody's really in, then an oxy hood gives you that best answer. Now, lots of places have gone to using a high-flow nasal cannula because it's easier than CPAP. And even the easiest CPAP apparatus is still more unwieldy and harder to use than high-flow nasal cannulas, with vapotherm being the most common. And if you do vapotherm or high-flow cannula right, you probably give a little bit of extra airway pressure, but not a whole lot. And it's important in newborns that you use the right size cannula. It shouldn't be any more than 80% the size of the nostril. Otherwise, or the nary. Otherwise, you're getting enough of a seal, you're not going to be able to predict what your airway pressure is. People have shown if you include the nares and the babies, you can get CPAPs that are high on a high-flow nasal cannula, just like you can on a 1 liter nasal cannula. So, now what do you guys have as far as what you stabilize a baby that's having respiratory distress? What do you typically use?
Oxygen.
Oxygen? Okay. You have regular nasal cannulas? How about high flow? No. And CPAP? No. All right. Now, so the high flow cannulas work by not only giving you a little bit of extra airway pressure, but they also, that high flow probably has a function in flushing out the CO2 from the system in a way that's different from either CPAP or a regular nasal cannon. And then also with the high flow cannons, there's a part of how they work that we don't know. So, but people have gone to using them thinking that they're just so much easier to use. But the problem is, and where people have gotten into trouble, and a couple of our referral hospitals have done it, because they don't understand that still, if you're keeping a baby on that, and you're going into hours to days of care, and they're still on a high flow cannula, you now have a higher risk with the patients, because they're needing more than just a little bit of oxygen. And that, and I've seen centers get in trouble with those, where those kids either have a thorax or they suddenly get a lot worse and need intubated. Now, this is another sticking point that I've run into in many of the centers, and this is whether they take care of kids for a while on CPAP or high flow cannulas, or just when a baby's born that's really sick, is in your institution, if a baby needs intubated, who does it? And who does it at 2 in the afternoon versus who does it at 2 a.m.? And that's one of those things that I encourage every hospital to have their algorithm for who's going to do this. Or if you who do you call to intubate a baby? Is it anesthesia? Is it the ER doc? Is it the pediatrician or family practitioner at home? And that does often vary at a different time of day. And to know who does that and then practice that, because this is not something you do very often. That if you have a baby that is goes apneic in newborn nursery at an hour of age for whatever the reason, whether it's septic shock or whatever, then who do you call to intubate? And if while you're waiting for somebody to come to intubate them, how do you stabilize that baby? Do you do bag and mask ventilation? Do you have a TP resuscitator? Do you guys have a neopuff?
No.
That needs to go. We need to get you a neopuff. Have you all seen them before? They're wonderful, and the thing about a neopuff is, I wish I'd invented it, because they're cheap. That they're $1,000. There's no electricity involved. Just runs off the wall air and oxygen. And it is it's very good for bag and mask ventilation. It's essentially just a air-driven little ventilator. You can give breaths through it hooked to an ET tube, or you can use it for extended bag and mask ventilation. And it's something that the NRP strongly recommends everybody have. And not only to use as a stabilization sort of device, whether through a mask or ET tube, but also, when you're doing bag and mask ventilation, it gives you a nice, steady, same pressure, and makes it a little easier once you get a good seal to keep it. So we will look into that. How about laryngeal mask airways?
I don't think we have them for neonates.
Because they make them down, you can use them down, you make a size that goes down to 1,500. For the very low birth weight, they don't. But do you have one for?
I think we only go down to like a 2, maybe.
Those are both things that NRP suggests, so we will